Thank you, Laura. Thank you for staying in aniridia patients' involvement. So it's really nice. So I know now we have seen a lot of things, and so I don't need more for the introduction of aniridia, congenital aniridia patients. And the question is, and that's why we will discuss that, is why guidelines? The question is why guidelines, and who or what for? So first, because we need an early diagnosis. You have seen that we have patients that have been diagnosed adult age and just when they had their children. So we should go to an early diagnosis. The second one is to detect Warger syndrome and Gillespie syndrome also, because of course the prognosis is not the same, the workup is not the same, the management is not the same. And so the question is what to do and what not to do. Not so simple. And of course, propose treatment. We know we don't have a real curative treatment at the time. So that's why it's quite complicated, but we have, of course, treatment. And when and what genotyping, when to go, where to go, how to go there. And so also these guidelines, for who are they? They are for general ophthalmologists. Of course, this is a rare eye disease. So it is very difficult to find an ophthalmologist that never seen a congenital aniridia and to know what to do. So that's why it's important to have some guidelines. It's also important for the geneticists, because even if the geneticist is aware of that, he doesn't know everything about the clinical implication, of course. It's of course also useful for the pediatrician. It's also useful for the general practitioner. It's also useful for optometrists, and could be optometrist, and I don't know, because in France we have only optometrists. But also it is important for patients. They need to know, and they need to know what to do. So we created, we created work groups for guidelines, and we have different possibility to go to guidelines. There is first the cost action with work group, and thank you for Neil, because he was coordinating these big meetings and thinking, and it is very useful because when we are together, it's really useful and very relevant. The second one is Aniridia Europe, a scientific committee, and involved with Laura also, and we work on this, and for ERN, and the last one is ERNI work group with Laura, and so you see that we can work on these guidelines with different possibilities, with different entrance point. So we have a French cohort. You saw the patients, for 20 patients at a time, but every week, or not every week, but every month, I see new patients. And so we just edited French guidelines because I'm coordinating a reference center of rare eye disease in France. This rare eye disease center is named Ophtara, and there is 20 other centers in France that I'm coordinating. And so we have a method. It's not only for aniridia, of course, it's for all disease, not eye disease only, all disease, and there is a method to do it, which name is PNDS for protocol. The guidelines is a special PNDS, and there is meta-analysis, there is translation. It's shortened that there is only 50 pages, so this could be long just for guidelines, but it's accessible for everybody in France. It's in French, of course. I'm so sorry. It's only in French. But you have Google, so it's very easy to do it, of course. There is also in Swedish. No, it's okay. It's a joke, of course. And so this was a PICO method. It's population intervention control outcome. And it's important because it's based on the literature review in different databases. So this is a real method. And this is HIS method, which is High Authority of Health and the French PNDS. And there was evaluation grid, the criteria for good practice, 4 pages for general practitioner, all recommendation indexed in a special format publishers. And this is an example which is not aniridia, but which is for albinism, and it was published this way. And so there were, I don't know if I put the work group, there was of course a work group of experts in France, and there were PubMed search, keywords, and today now there is guidelines that we are doing with Cost Action and Aniridia Europe. The other thing is, in another way, we can go to Aniridia consensus method. And this is the one we did for ERN work group, ERNI work group. And in this work group, all ophthalmologists are rare eye disease specialists, or pediatric ophthalmologists, or ophthalmology specialized in cornea, or geneticists. And we just ask what are the relevant questions we can propose to the defined by expert work group, and we try to get a consensus for all the question, or we change the form of the question. So what are the more important? We have clinical signs for aniridia diagnosis. So suspected visual impairment as nystagmus, photophobia, dark colors of the eye, wandering gaze, ophthalmos, corneal opacity, leukocoria, or microphthalmia. So all these signs could be an entrance to understand the diagnosis for the parents and for the doctors, of course. But the first thing, if we do a diagnosis of aniridia, we need to detect or exclude Warger syndrome. We need to detect or exclude Gillespie syndrome. Even if you don't have access quite easily to, if you don't have access to genetics, for instance, a very good phenotype could be useful. For instance, for Warger syndrome, if you have genital anomalies, if you have some mental retardation, is not a mental retardation, because when this is a baby, it's very difficult, of course. But if you see there is neurological problems, when you have also very deep neurological problems for cerebellar ataxia, for Gillespie syndrome, so you know, even if you don't have genetics, that there is a problem, and so maybe you can go and find out. So this is important for the aniridia diagnosis. Also, aniridia differential diagnosis, first workup. So there is suspected differential diagnosis with dysgenesis of the anterior segment. You have seen something we demonstrate, and we have seen with Sophie Valex, with Maria Musaggi, with all the speakers also. There is sometimes very different phenotypes, and that is not so easy to make the difference. Because sometimes I've seen a partial aniridia, which could be really PAX6 related, and it's PTX2 related. And so it includes all the other dysgenesis of the anterior segment, including Axenfeld-Rieger anomaly, Peters anomaly, and we know that Peters syndrome or Peters anomaly is sometimes not the good term, and it could be congenital glaucoma. We have some congenital glaucoma which are really PAX6 related, or which are, you have congenital glaucoma with aniridia, and it's CIP1B1 related. So sometimes you don't know. You can look at the phenotype. Sometimes it appears very simple, but some other time it could be very complicated because you don't know exactly what is the gene which is related to. So iris coloboma, I told you something, just look, if it's vertical, it could be if it's not an iris coloboma. That's what I just teach to my students. And also sometimes just hypoplasia with nystagmus, and it is another gene. Could be also colobomatosis microphthalmia, correctopia, which can enter in an Axenfeld-Rieger anomaly, but it could be also PAX6 related, and sometimes oculocutaneous albinism, because there is only an foveal hypoplasia. And it's very important in this sense to have the grading of the foveal hypoplasia, because if you have a complete aniridia, I mean in the phenotype, but you have no foveal hypoplasia, think it may be not a PAX6 related gene. So this is very important because it gives you more possibility to understand that. The second one is complications. So we have seen that AAK or AAK or ARK, complication of the cornea. So you need to have the grading, the neovascularization, you need to understand that, and that's why we have also guidelines. It's also interesting in cataract, early onset type, cartwheel, anterior subcapsular. We found that when you have cartwheel cataract, you are an aniridia, you can know this is a PAX6 gene anomaly, mutation or deletion, I don't know. But you know that just looking. So sometimes the phenotype is very, very important. Glaucoma also, prevalence, largely superior to 1-2, and could be congenital. Not so obviously common, but it could be this way. Aniridia treatment, and so we have palliative treatment, but they are very important. And that's why when we talk about is the glaucoma treatment impairing the ocular surface, but the problem, you need to treat the glaucoma. You need to treat. So you have to find the best treatment for the ocular surface, but for sure you need to treat glaucoma first. So medical treatment, we know that preservative-free are really mandatory. No soft contact lenses, tinted spectacle lenses. For the corneal limbal stem cell deficiency, preservative-free, of course. Lubricants, and Peter just said about the complexity of lubricants, but it's very important. Autologous serum is also a very good possibility. Surgical cataract management, AAK worsening, fibrotic risk. No really artificial iris implantation, just like this. There is high risk of complication, and we will go to a paper with Vito Romano to know about the complication. We can have that. And glaucoma management, it's of course complicated, but for first medical, except for congenital, and then surgical. So management also of visual impairment, and it is not nothing. It's very important also. It's re-education and rehabilitation for vision. And it is important for the quality of life, because you can give for the patient, you can give something else. And so there is optometrists, low vision optometrists, there is vision optical aids, there is mobility instructors. Of course, there is tinted corrective spectacle lenses, but could be also optical aids, very interesting. So this is not nothing, it's very important. So if we go to a take-home message, I just have one slide, I promise. So there is Aniridia guidelines, they are relevant for the best management and treatment of the patient. Early diagnosis of the congenital aniridia is very important. Exclude Warger syndrome, it's life-threatening. Gillespie syndrome, of course, because it's neurological problems. Detect and treat complications, AAK, glaucoma, cataracts, strabismus. We didn't talk about strabismus, but it's important also. And low vision rehabilitation and aids are really very useful. and orientation and teaching of patients is also very accurate. So thank you very much for listening. I know it's very it's very late, but thank you very much.